Our next speaker for the morning, and I'd like to welcome Ma'am Dr. Sudha Chandrasekhar, former Executive Director, National Health Authority, and Advisor to Health System Transformation Platform, HSTP. Welcome, ma'am.
A very good morning. Can I have my slides? Okay, thank you. So, how are you all? All of you had breakfast? Okay, because these kinds of early panels are also a difficulty, right? Just pre-lunch, post-lunch, the first session, everything needs energy to be built in. And the momentum builds as the session progresses. So I think being a second speaker, I have some leverage of time. So thank you and happy to meet you all. Because I've been engaged with both Karnataka government UHC programs and also the national government Ayushman Bharat PMJY programs. And my main role was health policy and hospital engagement. So I've had lots of interaction with hospitals and understand the processes. But today I'll be touching upon more on quality healthcare, and that is through policy, collaboration, and innovation. So that's the topic that I will be dealing with. So when we say ensuring these kind of quality healthcare, I think policy has a very important factor, because many a time, unless there is some guideline, some kind of a push, things do not move forward. So one of the key policies that I would like to tell you is also about the universal health coverage that the government of India has adopted as a part of the SDG goals for 2030, right? So in that, one of the key scheme that's being implemented is through the Ayushman Bharat, which has two wings. One is the comprehensive primary healthcare approach, that is for primary health centers upgraded to Ayushman Arogya Mandirs, and the Pradhan Mantri Jan Arogya Yojana, which is more in hospital care for secondary and tertiary services. So these two form a very important component of our move towards UHC. They're not just the one, but a significant part, because there are other key policies such as the National Health Mission, both urban and rural, which also have a huge role to play in delivering healthcare to the population. So these two are very key. And the second thing is also engaging strategically. The strategic collaborations more at the interdepartmental convergence, because earlier when the health schemes or health programs were being implemented, it was more largely health department role. And even though other departments were implementing, there was no coordination at all. So nowadays, many of the health schemes are brought together and ensure that there is interdepartmental convergence. You can remember that RSBY, which was implemented by the Labor Department, was moved to Health Department. There are many schemes which are being implemented by other departments, but slowly converged so that these kind of activities are guided by the Health Department, even if they continue to be engaged by other departments. So that is one. And when we say collaboration in the community or the patients or the public, that's very, very important. So we need to engage them effectively, and of course the private sector. We know that majority of the healthcare, especially outpatient healthcare in urban areas and in most rural areas, are also provided by the private sector. So public health does form a key role of the government, but government has to work with the private sector in majority of the schemes implementation. You've all been partnering, supporting, and the recent example of COVID where everyone came together, right? So in delivering healthcare. So in terms of that, private sector collaboration is a very key factor in delivering healthcare. When we look at innovations, yes, earlier innovations used to happen in silos, and there was no channel to bring in these innovations of healthcare into the mainstream, and the process was kind of not very clear. But now we have two key, institutionalization of these newer technology. One is the health technology assessment in India, which is under the Department of Health Research, which actually ensures that newer health technologies are assessed and wherever it is recommended, scaled up, and guidance given to the respective governments to consider it for adoption and scale up. So that is one pathway. And for newer drugs and treatment methods, also we have the HEFTA, which is under the National Health Authority. So the Health Financing and Technology Assessment Unit. So wherein the requests for new treatment options to be considered under the larger public health programs can be put in, and that will be looked into how it can be processed for further evaluations either through the DHR and other mechanisms. So in that sense, we are building up ways in which how innovative approaches, the scale up at the national and the state level can happen, and made sure that that will progress. And as I said, for UHC, these public health funded insurance programs are also very key, along with the private insurance, which only a few, maybe less than 2 to 3% of the larger population have. These public health funded insurance programs contribute to around 40 to 50% of the population being covered both at the national, as a part of the national scheme, and also an expanded state level scheme. In Karnataka, we have the Ayushman Bharat Arogya Karnataka scheme, which covers almost 100%, right? Because for both APL and BPL, these schemes cover. So in that sense, each state has its own way of ensuring these expansion of the health insurance schemes. So in that sense, what we also need to do is, apart from just increasing the coverage, the quality of care, and the value-based care approach is something that, as a policy that has come up to make sure that the actual healthcare outcomes for the patients are looked into. And patient experiences are also given a lot of weightage. When we say we are delivering healthcare, the weightage to these kind of aspects also needs to be done. And secondly, when you're ensuring the coverage, the missing middle, what we call, is also important, because they are also stuck by catastrophic expenditure, especially for high-cost services. So that is an area which still needs to be looked into. There are some states who have gone ahead and implemented this. We have Odisha, we have Karnataka, Uttarakhand, Meghalaya. Some of the states have gone ahead and implemented as a universal coverage for all population, irrespective of their economic status. But there is still a lot of efforts that needs to be done in on how to cover this missing middle. And when we look at, again, quality of care, the standardized care is very important, because whether the patient goes to Kaveri Hospital or Ramaya Hospital, we expect that the quality of care needs to be similar, and what the patient receives. The variation should be minimal, which is only with regard to the patient's characteristics, but not as a standard. So those kind of approaches, like standard treatment guidelines, has been brought in both by the ICMR and by the NHA for implementing the programs. So in that sense, we need to push that hospitals and treating physicians adopt the standard clinical care guidelines and follow that, and that adherence would also benefit in improving the health outcomes for the patients. So when we also look at one of the key things that feedback we receive in these kind of public funded programs is the reimbursement part, right? The reimbursements, either it's not enough or the way it is structured is not proper. So in that sense, one of the other innovative approach that NHA is also trying out in pilot states is the diagnosis related groups. Because we know that every patient is different. Apart from the standard care, there are resource differences in treating the patients. So that is captured during the diagnosis related group, wherein the care pathway for that patient is mapped, which is very specific, and based on the diagnosis, the reimbursement could also be modified. So it's not a flat rate for all the patients, but as the kind of patient's complicated case versus standard case, there is some variation in the kind. So this is still in pilot stage, so it takes a little bit more time, because these are advanced provider payment mechanisms which are being used in countries like Thailand, and Indonesia and many other countries, but it is still in India, I think the PMJY is the first scheme to do this, even as a pilot, whereas most of the schemes follow the case-based payment methods. And further, I think in 2022, we also took up the ICD-11 ICHI coding, which is the latest in the International Classification of Diseases. And this is very important because when we have to assess the morbidity pattern at a national and international comparisons, ICD-11 coding would be really key. And WHO has come up with this, and it is mandatory, and India is a signatory for adopting the ICD-11. So as a gradual expansion, this ICD-11 coding would also be introduced. I know majority of the hospital in the HMIS are linked to ICD-10 or ICD-9, but I think the ICD-11 is very friendly. Even you don't need a medical person to do this. It can be actually handled by a data entry operator for the coding with proper little trainings. So it's like Google search. So you can just type the diagnosis and the coding automatically comes in. So it's a very simplified version of the ICD coding, and that is something I think if I would also, as a part of your own updation of the hospital processes, if you move into the latest coding, that will be really helpful. And AI, I think it's always the buzzword, and making sure that AI is integrated within the healthcare, not only for the kind of solutions that it can give, but also for data analysis, because it can handle huge data, and AI-driven triggers are already implemented in many health schemes, so that the kind of frauds and issues can also be flagged off and addressed. So in this sense, these are kind of emerging technologies, but how do we adopt it within our own schemes is also very important, and especially latest TB solutions for AI for follow-up dropouts and adherence monitoring and tracking. So all these are really important, and in key health programs this will form a very big aspect. Just a couple more slides. And most important is also the referral linkages and continuum of care, because we all look at very curative kind of processes and just the treatment part when the patients come and seek care in hospitals. But we also need to ensure that there is a seamless flow of patients from primary care to tertiary and follow-up as required. And that continuum of care is also tracked. And for that, I think ABDM would be very, very useful. And I would let Narendra talk about it more when we look at how longitudinal data and sharing especially helps in referral linkages. And recently, our Honorable PM also announced that as part of their manifesto that elderly patients would also be kind of covered in the schemes, and irrespective of the economic status. Let's wait and see how it rolls out. But I think it's a very needed intervention because of the high cost of services that are required for elderly population. And with primary healthcare, the continuum of care linkages is very important, as again, not only with the local health teams. I think the CHO, the community health officer at Arogya Mandars is very, very essential person now when we look at like how ASHA was for a lot of our public health programs. The CHO is for the clinical and the curative care processes. So it's very important that we engage with them and ensure that they are strengthened. So as we look at urban healthcare is again another key aspect, because the way how it is delivered within the rural and the urban, they have slightly different challenges, and it's important to have good urban healthcare models, and for which again community engagement. And recently when we had an interaction with the National Urban Livelihood Mission, NULM, who have thousands of SHGs even within Karnataka. So the self-help groups could be one very critical of how do we engage community, and we are working with the department to look at how do we scale this up to identify an Arogya Sakhi in every SHG and orient them on the key health schemes and key health facilities that people can actually avail free so that they don't engage going into non-empaneled facilities and having out-of-pocket expenditure. So it's creating the linkages within the public health schemes and also the available health services within the system. So I think that is one. And leveraging private sector, I would say, I'm sure most of you are engaged with the government schemes. Can I have a show of hands? How many hospitals who are present here have already engaged with almost all? Yeah. So that is very important, because when we say we will provide care for 40% or 50% of our population, and we have to have simultaneously the number of empaneled providers to deliver that care. Currently, I think at the national level, we have around 28,000 hospitals who are part of this program across the country. So it is important that we expand that further and also make them active, because engaging and signing an MOU is not enough, but we need to ensure that the care is provided to the people and they're active and provide the care. So in that sense, the private sector would be a very key factor. And digitization process, I will not spend much time because I have another speaker who will be dealing with it. But I would definitely say that ABDM would be a game changer, and especially for linking up the health information and making sure that it will benefit the patients and the doctors also, because they will have the required patient information to take more informed decisions. So that will be really key. So the HEFTA and HTA and I have already covered, but please do, if you have any new innovations, go through this process and encourage people whom you know to apply it through the portal so that it can be looked into by the relevant people and identified for further review and scale up. So that is very important. And data is a key. Data is a new gold, I would say. Right? So the data mining would be very, very important, and morbidity data has much wider uses, and it also helps in policy making. So it is very important, and I'm sure most of your hospitals are HMIS compliant, so, and you also keep looking at the data, but please do use your data at the local level to look at the morbidity patterns that your hospitals are actually carrying and what needs to be done to improve the health. So in that sense, overall, all these aspects that I covered are key to make sure that we have a very strong health system delivery. So, and improvements which are coming up, especially from the infrastructure also. I think we have the 15th Finance Commission and also the PM ABIM, especially building up the public health infrastructure. So I think with both the developments happening at all areas, public, private, and the kind of various innovative processes that we are bringing in, I'm sure this would really help and develop the healthcare of the population. Thank you very much.